Dr. Stephen Taylor, thank you so much for joining us here on the Science of Psychotherapy. So great to meet you.
Thanks very much, Matt. Nice to meet you and Richard as well.
Yes, I'm here as always, and fabulously excited. I mean, obviously the title very, the psychology of pandemics, very, very here and now, and a lot of people have drawn their attention to this thing because it is so consuming. But there's a lot more in this book. There's a lot in this book. So we'll try and see if we can get through, but a lot of help for actual therapists. And what do you think, Matt? I think we probably just can we give a little bit of a background to, what got you into writing this book, some of the directions? We've had a few words about your professional career, but some of your own personal comments.
Yeah, my background is in, my research and clinical background is broadly in anxiety disorders, post-traumatic stress disorder, OCD, so anxiety and related disorders, including health anxiety. By that I mean excessive health anxiety, what used to be called hypochondriasis in the olden days. Anyway, 2018, I started coming across newspaper reports interviewing historians of medicine and virologists and epidemiologists, because it was a centenary of the Spanish flu, the so-called Spanish flu. And so they were interviewing these people and about the next pandemic, and they were all predicting another pandemic was coming. And they said, look, these aren't once in a lifetime experiences. These are more common than people recognize. And I got interested in that. So I started reading around it, and the more I read about it, the more I realized, wow, psychology is hugely important in pandemics, because we know all this now. But back in 2018, I thought, wow, psychology is hugely important, but the research and the clinical work is all scattered. You have vaccination hesitancy, you have anxiety disorders. No one had ever put it together. So I thought, well, pandemics, psychology is hugely important because they influence how people react and whether they adhere to social distancing or vaccines or how distressed they become. I realized no one had ever put it together into a single volume. So I did, and I sent it to my publisher in early 2019. And he rejected it. He said, this is the guy who's been publishing my books for 20 years. He said, well, it's an interesting idea, but no one's going to want to read this. And I felt really crestfallen and dejected, because I thought, no, this is hugely important. So I found another publisher, and it was published about a month before COVID-19 broke out. So I knew a pandemic was coming, but I didn't realize it was coming that soon.
Wow, this is a guy who rejected the Beatles because no one's going to be interested in four bloke bands.
So what were conversations like with your original publisher after the fact?
We get on fine. I bugged him a little bit about it, but not too much.
Well, it's not often the author can go back to the publisher and say, "Well, I told you so." But well done. But how fascinating, Stephen, that you were thinking this is a relevant topic. Before there was this huge pandemic in existence, because one of the things that I keep hearing from a sort of in general public is, no one could have expected this, and from politicians as well. And you're just a perfect example of the fact that the science, the area of science, and was well aware of this. But even in psychology, in the mental a basis of us, this idea of how are we going to pull ourselves together. Maybe one of the things, because it's really nice, you sort of start chapter 1 with what I think is a pretty reasonable question. What is a pandemic? And from this psychological point of view, how can we describe, because most of our people are therapists, that when they're talking about the pandemic, it's not like the technical term of saying it's a disease that traverses countries. It's actually something more than that, isn't it?
Mm-hmm. Yeah, well, and there are different kinds of pandemics. Put simply, a pandemic is a global outbreak of disease that spreads everywhere. And it's got to have some degree of seriousness to it as well. Otherwise, the WHO wouldn't bother defining it as a pandemic. The definition is arbitrary. How many countries does it have to spread to? Well, most of them. What kind of infections do you need in the countries? Well, it has to be community-based infection, that is, infection spreading within a community rather than infection being brought in. So it's a kind of a fuzzy concept, but it's clear enough to set the stage for looking at the psychology of pandemics.
Yeah, because it is also, I mean, there's the disease that spread, but there's also ideas that that accompanied it that spread, which is, of course, where we're getting more into the psychology, isn't it?
Mm-hmm. Exactly. And there's a huge parallel between conspiracy theories and viruses, in fact. Conspiracy theories, don't get me started.
Yeah. There's a chapter on this too. Yeah.
Well, I've been working on the next book, and the amount of material is just boggling. But conspiracy theories, just like a virus, they need a host. They need a conspiracy theorist to defend the theory, and just like viruses, conspiracy theories mutate and reassort themselves. And so, what we're seeing today, the conspiracy theories around COVID are recycled old conspiracy theories. So, yeah, the spreading of fear and beliefs and attitudes is very much like the spreading of disease.
This goes back to Dawkins and his term memes when he was doing that, which then was, Susan Blakemore did some fabulous work on. So this idea of an idea that travels across hosts. Oh wow, yeah, really interesting.
So now we're in a sort of a unique position than we were sort of in previous times with social media and the way that we communicate. And so can you talk to us a little bit about how that plays into the psychology of pandemics?
Mm-hmm. In a very real way, this is the first pandemic in the era of social media. I mean, there have been other pandemics. In fact, there have been more pandemics than most people realize. There's been about 20 in the last century. But we had two pandemics in 2009, the Zika virus pandemic and the H1N1 so-called swine flu pandemic. But even then, the internet wasn't as developed as it is now. And now we're getting in a fuller form, social media and the 24/7 news cycle and the global digital interconnectedness of the planet makes this pandemic different in many ways from previous pandemics. Different in one way in that everything that happens gets sped up or it's bigger and faster than what it would have been. So just to give you an example, the anti-mask movement that we're seeing today, I mean, that's virtually global, and there are recurrent waves of protest, and that's been fueled by social media, of course, the political aspect of it as well, Republicans not wanting to wear masks, particularly Donald Trump, but that social media has fueled it. Now, compare that to 1919 during the Spanish flu. The anti-mask league was formed back then. For the same reasons today. These people said, hey, you're not the boss of me, you're not telling me what to do, and I don't think masks work. So that group got together in San Francisco and they formed a protest movement. That fizzled out. It lasted a few months. They had one big meeting and that was it. They didn't have social media. It's one thing to go up putting ads in newspapers or flyers on storefront windows. That doesn't get the traction that social media gets. So this is a reason why conspiracy theories and the anti-movements are getting a lot more traction, a lot more attention than they would have got in previous years.
Is that sort of because like going back to the 1919 one, 1918-19, so the absence of substance, so the conspiracy theory doesn't prove itself, and so therefore peters out. But actually the social media is the substance, regardless of the realities or truths or efficacy or science or anything. The medium is the message on McLuhan stuff.
Marshall McLuhan said it correctly. Just to give you another example, in 1919, in the New York Times, the health authority there mentioned a conspiracy theory that he'd heard, he thought that had some truth to it. And the theory was that German agents were arriving in Manhattan under the cover of darkness in U-boats. So they they surface their submarines, get out little rowboats, row into Manhattan, and then run around through the saloons and cinemas distributing virus everywhere.
Wow.
Right? So it sounds like flu as bioweapon. And in every pandemic that I've studied, we've come across the flu as the organism as bioweapon conspiracy theory. Now, what that makes that different then versus today, this conspiracy theory was written about by an authority in a leading periodical, the New York Times. It essentially disappeared. There were occasional mentions of this conspiracy theory because the flu was during World War I, so the Germans, US was at war with the Germans. It got a little bit of attraction, and then it kind of died out. It really didn't influence people that much. Contrast that to today, where President Trump getting up and calling COVID-19 the Wuhan flu or the Chinese virus, that just stoked racism and created unprecedented levels of discrimination and racism.
Mm. So therapists, Matt and I were talking about this before, that all this stuff, as you say, we could go on for a million years about the humanistic aspect of it. But our poor therapists sitting in their room with someone who comes in, and I've also deal with it with some of my supervisees as well. What are some of the ways you've talked about that in the book?
That's quite evolved. What I was talking about in the book was I pointed out that we're going to have to move away from the luxury of sitting in your own office and seeing patients one-to-one. That's not going to work for two reasons. One is there's just too many patients to be seen during a pandemic. Too many people are distressed some have clinical conditions, some are more in the adjustment realm. Too many people scattered too far outside of major metropolitan areas. And of course, there's the social distancing component. So we had to move to an online format. And I think people are still doing that today in a hybrid sort of model, a mix of in-person and telepsychiatry, if you like. But that's something that's had to come up. And of course, clinicians are facing all kinds of other challenges. You probably know what it's like to do therapy over Zoom. It is a little different. You can't pick up the cues from the patient. You can't really watch their body language. You can't see them walk into the office. Is the patient motorically slowed, for example? Do they smell of alcohol? Are they disheveled? I can't see half of those cues on the screen, but it's better than nothing. So I'm primarily focusing on the audio track.
Yeah. Now, so we talked about social media. We're getting bombarded with all sorts of narratives that obviously can cause stress and anxiety. What other things are we seeing as therapists dealing with people's mental well-being?
What we're seeing at the moment, we're in a state of so-called pandemic fatigue. And it's because the mental health consequences of pandemics are largely due to lockdown, not so much infection. Although people who do get infected and who become seriously ill, of course, they are at risk for developing various problems like post-traumatic stress disorder. But it's lockdown that affects more people because we're sociable creatures. As socialization or sociability is etched into our genome, and we're told to inhibit that, to stay inside, to stay isolated, and that wears over time. Lockdown or social distancing, it's not a long-term strategy. It's a short-term, well, if you like, a circuit breaker to reduce the spread of infection. So unfortunately, we're stuck with social distancing. Lockdown is the best method we have for pandemic contagion, but it wears people down. And I think that's some of the bigger things that, at least here in Vancouver, that we're seeing. We're seeing a lot of people out there in the community. They might not have DSM or ICD diagnosable disorders, but they're suffering from recurrent anxiety, low mood, and irritability. And so suddenly I'm seeing signs around the stores, please be kind, please don't be rude to the shopkeepers if you're frustrated. So there's a lot more irritability there. And of course, we're seeing that in our patients as well.
Yeah, so we're hearing a lot of reports about increased suicide rates, increased depression, domestic violence increasing. So there's a whole range of issues that are cropping up here directly because of lockdown.
You're right. But suicide is a really interesting and important one. There's been a huge amount of data and research done on suicide during COVID. There is yet to be a clear picture to emerge. There's all kinds of variability. We know that depression has increased particularly over the course of 2020, over lockdown, but it's not clear whether there has been an increase in suicidal attempts.
There's an interesting thing that I haven't done any work on it, but I've done a lot of my master's thesis was on suicide and various other things, so it's been something very, very strong with me. And I haven't seen a great deal of change in statistics, but I have seen some change anecdotally in motivations. So there have been some things that the notes have clearly shown that they can't stand, they can't bear the current crisis is doing it. But I've also had some anecdotal discussion of people who are saying it gave them something to fight. And there's actually people who were suicidal who shifted their frame to a little bit more something which so there may be this double-edged sword of the process.
Yeah. Exactly, Richard. I agree with you entirely. There's another aspect to this. I think that's important for clinicians to know. Historically, suicides have spiked when there have been masses of unemployment, particularly among working-age young people. The Great Depression in the 1930s is the classic example. But even if you go back to the Spanish flu, at the end of the flu, 1920, 1921, there was a minor economic recession, and that was associated with an increase in suicidal behavior, particularly in communities that were subjected to lockdown. Now, the reason I mention this is the IMF last year published this gloom and doom report predicting a Great Depression after COVID that would be worse than any that we'd ever experienced. I think there was an exaggeration, but it is an important point. If we come out of this pandemic and there is an economic recession, we as clinicians should be extra diligent in assessing suicidal ideation because it has characteristically spiked before, and it's hard to predict suicide at the best of times. But sudden unemployment of a working age individual who has responsibilities or a family to support, that's going to be a flag that I would be careful in pursuing.
Yes, and in Australia especially, we have a sort of the backbone of the economy is small business, and small businesses are suffering terribly because of restrictions.
Absolutely, yes.
And individual government behaviours are a part of it, because I imagine that because this is the difficulty with something like this is you have just current events, so it's almost like a counselling process. You're dealing people with current events, but then of course these are tapping into older unresolved issues, so they're for more the therapeutic type of event. So do we need to be aware of that? Trying to find that distinction. Is that a distinction of what's just the here and now? Because people say, I'm anxious about COVID. I'm going, well, yeah, so am I. There's nothing weird about that. But then they start saying, and this, and then up comes the old story. Is this something that therapists need to have some greater sensitivity to the here and now and the historic stuff?
Yes, I think so, because as you pointed out earlier, there's been a range of different reactions to the pandemic, to COVID-19. And to understand those, we need to understand the person's situation in the here and now, but we also need to understand the context, the historical context. For example, in our research, we were finding that the most anxious people, not surprisingly, they have a past history of anxiety or depressive disorders, or a history of intolerance of uncertainty or excessive health anxiety. So we need to know that. We might think, otherwise you might be mistaken. You might think, oh, I'm just looking at an adjustment disorder. This person is just anxious because of COVID. You need to look at the history. It could be that this is simply another expression of a long-standing disorder. It could be OCD, or it could be somatic symptom disorder. It could be anything.
Yes, a very good point. So exacerbation of pre-existing. Yep.
Your other book, which I thought was terrific, and just look at my notes, which is Understanding and Treating Panic Disorder, which, as you were saying, you were dealing with anxiety and panic in bits and pieces, and that one, gave highlight in the sub note to that of cognitive behavioural approaches. Do you have a particular recommendation? Do you have a particular school like cognitive behavioural that you find more preferable? What's your attitude towards the approach? What the approach that therapists could or should or can take?
we've got all these tools which are moderately effective, and there's no magic bullet, and one strategy works well with one patient, one doesn't work so well with another. They all have the same kind of theoretical rationale. So I think it's a question of being able to pick and choose. Sometimes standard Beck-style cognitive therapy is all you need. Sometimes you need to add in something from dialectical behavior therapy, such as the crisis containment things. And then, of course, there's the mindfulness strategies can be helpful, and experiential strategies. So I draw from all the sorts of tools used by cognitive behavioral therapists to help patients.
And this segues really sweetly now into this chapter that caught my eye, which was the behavioral immune system, those capacities within the client. Could you expand a bit about that idea?
Yeah, it's a really interesting idea. It's the idea that our biological immune system is not enough. It's not going to protect us from microorganisms. It won't protect us from parasites, viruses, or bacteria, because most of them are too small to see. And so we need to have evolved a psychological system for detecting cues to infection, and that's the behavioral immune system. And so it's a system that relies on cues to infection or cues to disgust. So bodily secretions, phlegm, saliva, feces, urine, they trigger disgust reactions. And just like anxiety is generally an adaptive emotion, or fear, it causes us to back off and keep ourselves safe. The emotion of disgust is generally an adaptive emotion. It keeps us away from putting contaminated things in our mouths, from doing things that only young children would do, like don't put dirt in your mouth or stuff like that. So it's a system of detecting cues. But this system tends to err on the side of false alarms. And from an engineering perspective, you want a system that's going to err on the side of false alarms, because no system is perfect. If I have a smoke alarm in my house that has the opposite, that errs on the side of caution, I could burn to death. So it's better to have some false alarms and be safe. And the same with the behavioral immune system. That said, there are individual differences in the degree to which that system is activated. And that's called the perceived vulnerability to disease. So some people find they're very readily disgusted, or they're very readily made anxious by the sight of infection, or people who look infected, or sickly looking people. Now, it goes a step further than that. From an evolutionary perspective, we as humans have got infected and got very ill when we've interacted with foreigners. Yeah. So the classic example are the European explorers to various continents. I think one of the most dramatic examples is South America. They brought venereal diseases, they brought smallpox, they brought influenza. The locals had no experience with these and no pre-existing immunity, wiped them out. So part of this behavioral immune system is almost like a built-in xenophobia, that when we become anxious about our health, we tend to be wary of strangers. And
that's really interesting.
That is an adaptive response. But taken to an extreme, it turns into unacceptable things like racism and frank xenophobia. And that's expressed by the very, very anxious people, the people who have their behavioral immune system is in overdrive. They're very frightened of infection, and therefore they're very xenophobic and wary of strangers, particularly strangers that they've learned to associate with infection. And given former President Trump's blaming of China, people of Asian ancestry have been targeted out. And of course, the people who are highly frightened of infection tend to be wary of those individuals.
Right. And it sounds like there has to be like a feedback mechanism in play here as well to increase that angst.
Yeah.
Yeah, well, that's our cognitive evolution, is sort of social evolution that we do cognitively, where we can take a great idea and really screw it up.
Right.
We can.
Right.
But this and of course now I'm seeing two things, and this is absolutely fascinating. This disgust sort of emotion. It's really making me, my mind. I'm going all over the place. But that because you get disgust of the other, and particularly the suspected other, but also there's those who get disgust for themselves. So that intrapersonal disgust, is that something that therapists need to be really looking out for?
Yes, internalized self-stigma, internalized discrimination. I mean, that's been a topic of the research on racism for many, many years now. And I think therapists should be looking for that, but probing for it in a sensitive and tactful manner, because that could be very distressing for someone to have to talk about. But definitely we should be looking for that sort of thing.
Mm.
Yeah, because I mean, like my wife has a persistent sinus issue, which she's had, most of her life, broke her nose when she was young and so on and so forth. And she gets pretty annoyed at herself sometimes, like sometimes I'll say, what am I doing wrong? What are you angry at me for? And she'll say, no, I'm not angry at you. I'm angry at me. This seems to be something that you've just, and I'm just thinking of some of my recent patients. I'm thinking, oh wow, that's what I should have been more sensitive to. So thank you so much, Stephen. That's really, really important.
Well, just on that, I think self-directed anger is something hugely important that we as clinicians have maybe forgotten to look at. I mean, back in the 1950s, was that psychoanalytic theory that depression was anger turned inwards. So clinicians back then were looking for self-directed anger. I think that maybe today we're not looking at as much as we should do self-directed anger, not as an indication of depression, but as a phenomena in its own. Right.
Yeah. Now, can I just circle back to technology and media? Now, one of the sort of common bits of advice that we seem to hear is turn off the media, because your levels of anxiety is going through the roof, but you're watching the news, you're reading all of the posts and everything, which is just continually feeding anxiety. Is that something that you see and that you would recommend to sort of turn off that media flow?
It's part of the infodemic, as they call it. And people are just overwhelmed with information, and the challenge is to figure out which is useful and which is misinformation or even fake. We found in our research that people who spend a lot of time checking for COVID on the internet or the news are having nightmares about it and intrusive thoughts and traumatic stress-like symptoms. So for people like that, I suggest that they, on the one hand, they need to stay informed. I mean, for example, one example are mask mandates, which up here in Canada are changing all the time. We were without masks 2 weeks ago, and now masks are back.
Yeah.
So we're masking up. So obviously we need to stay informed to some extent, but limit your media consumption and stick to reputable news sources.
Yeah, pick and choose more carefully.
Yeah, some of my patients have described it as like going down a rabbit hole. They'll start off in the morning with their coffee. I'm just going to check the news, and one thing leads to another. One hyperlink leads to another. And before you know it, they've gone right down, and they're looking at some really scary, probably fake stuff, and they've spent hours doing that and are really agitated. So for those people, I suggest they limit their exposure and don't get your news from social media, because it tends to be sensationalized.
Now, I've got to just quickly, Matt, just because I've got an ADHD patient who is who's doing that. She's rabbit holing just because they get fixated and off they go. And I've just been saying, turn it off. I did some text with her recently. I just actually wrote, turn it off about 10 times because I had ADHD back at it. But interesting. Sorry, Matt. I was
just going to say, coming back also to being locked down, people are locked down, they're not going to work. So what are they doing? They're on devices and they're consuming media way more than they would be if they're out working and, doing the usual thing. Yeah.
True. So it's understandable that people are spending a lot of time. They're trying to keep themselves or their family safe. It just so happens they get seduced down this rabbit hole, and one sensational, fascinating news story after another. Before they know it, they're wired and anxious and having nightmares.
Which is the aim of media. I mean, that is the mechanism, the methods they use is to grasp your attention and to funnel you into their stuff, so to get ratings. I mean, I think we need to be a little bit straightforward with our clients too, saying that they're saying, "Oh yes, but it's so interesting." I said, "But that's their job. That's what they do. Right. It's your job to be discerning."
Absolutely, yes, I agree.
Yeah.
Now, Stephen, you're one of the leaders of the Psychology of Pandemics Network, which sounds fascinating. Could you just give us a little bit of an insight as to what that is all about?
Yeah. My colleague, Gordon Asmundson at University of Regina, Gordon and I have been collaborating for decades now on health anxiety mainly. And when the pandemic was emerging early 2020, we decided to put a grant together and use the book as a foundation for proposing an ongoing set of research to understand the psychology of COVID-19. And we were successful with that application. And we've been conducting multiple waves of assessment via the internet on adults from Canada and the United States since early 2020. We've just collected our fourth wave of data. And so we're using that to try and understand various aspects of COVID-19 and the psychology around it.
Okay, brilliant.
Yeah, so this idea that, again, if we bring brains together, we can produce a broader, more cohesive and more engaging focus. Or just another conspiracy theory. It just depends on what you think.
All right. Well, Stephen, as we sort of wrap up, is there any sort of final thoughts that you would like to tell our listeners?
Yes. Clinicians will be seeing disorders for which they have limited experience. Let me just go through the list briefly. We've got long COVID and that chronic fatigue aspect to it, which is difficult to, by the way, people with long COVID don't like people telling them they have chronic fatigue due to all the excess baggage that chronic fatigue has with it.
Yes.
But very few clinicians are experienced and trained in chronic fatigue. Post-traumatic stress disorder, at least I know in Vancouver where I live, most clinicians have very limited experience with PTSD, and we are seeing cases of PTSD after infection. There's prolonged grief disorder of the people who've been bereaved due to COVID. And that was a fairly common disorder prior to COVID-19. Roughly 10% of bereaved people were thought to have this disorder. It involves more than grief counselling. It involves, one of the treatments involves some kind of exposure therapy, which I've done with patients before, but it requires specialised training. Then you've got OCD and severe forms of health anxiety. So many clinicians will not have had experience with those disorders. That's okay. The main thing is that you're able to identify them and assess them and refer on. And there are going to be other disorders that we're going to see for which most clinicians will have had no experience. And I'm talking about functional neurological disorders.
Yes.
What used to be called conversion disorders or conversion hysteria, we're seeing those around the vaccines. People developing neurological reactions to the vaccines. And it's the way conversion disorders or functional disorders are presented to patients, it's a circuit problem. It's a software, not a hardware problem. But they are not uncommon. There's been a lot of reports in the media of people diagnosing them. Incidentally, it's not new. You can go back to all the previous pandemics just about and find something similar. 2009 swine flu, or in fact, there have been cases of kids being immunized against diphtheria and tetanus developing these conversion sorts of reactions. So we need to be on the lookout for those. Now, they typically involve a multidisciplinary approach.
I was going to say, I would imagine they're already under the, they've got a neurologist or whatever, but we have to deal with the psychological aspect.
And recognize it, as you say. I mean, one of the things we talk about is we don't expect everybody to know everything. 21st century therapist doesn't need to know it all, but it needs to know about.
That's right.
Exactly. And the interesting thing about these functional disorders is the treatments are psychological. So when I see these patients, I work with colleagues in the in our neuropsychiatric program in our department. And that division contains a mix of neurologists and psychiatrists. So when they refer patients to me, I can be reassured that they've been properly assessed for underlying medical conditions. The last thing I want to do is start treating someone who I think has a functional disorder only to discover they have the early stages of MS.
Right. Yeah, of course.
So it is tricky, but treatable with psychological methods.
Yeah.
Okay.
And it's great, Stephen. We've actually got a video that we've done a presentation from John Arden, who's does a lot of neuroscience, and he's done on long COVID. He did a 6 months of work on that. So our subscribers can come in, and that's a great little piece of knowing about. And another one that just was in the top of my head as we were going there is the body up stuff. So there's heart issues. So there's sinoatrial concerns there. So your heart rate and rhythm, which has vagus effects. So there's a bunch of these. There's a bunch of these things, aren't there? Yeah, man.
Yeah. We're all terribly integrated, aren't we? So all of these physiological things will have a mental impact.
Yeah.
Well, Dr. Stephen Taylor, it's been so great to discover you and to find out about your book. We will point everyone to that book and to resources to your website. But it's been great catching up, and thank you for being on the show.
Well, thanks very much, Matt and Richard. I really appreciate you having me on your program.
Oh, yeah. We wish we'd all read this in 2019 when it first came out. Beautiful.
All right, then. Thank you. See you later, then.
Thanks a lot, guys. Stay safe.